Thank you. Buenas noches. And I'm sorry, but that's the last Spanish I'm speaking tonight. I am very bad. It is wonderful to be back here in Guatemala with old friends for a long time and to meet so many new friends. I am honored, greatly honored to be here. And Dr. Beltadon has asked me to talk about something that's interested us for a while, about chronic cough in children. We've been studying cough for many, many years and have published a lot of guidelines, information, studies, research. And the reason for this is that cough is incredibly common and also incredibly expensive. 12% of the population reports having a chronic cough, and many of these for weeks or days on end. In a study that we did with a group from Italy, we found that in a prospective study of children with cough, we looked at over 400 children. We found with using the cough questionnaire, it disturbed sleep in both children and the parents. It affected the school and sports activity, but you all know this. So why do we cough, and what makes a cough effective? We say a cough is effective when it's able to expel material from the airways. And it begins with an irritant receptor in the airways, sending up an afferent signal to the brain to bring in a large amount of air, close the glottis, and then expel it forcefully. In order to do this effectively, you need to be able to have high gas flow and the endothoracic pressures. Patients who are too weak to have an effective cough can have severe difficulties, which is why we have equipment like the Cough Assist for patients with neuromuscular problems, stroke, or weakness. It's ineffective when the muscles are weak or when the mucus isn't thick but sticky. So why do we cough? Well, yes, these are my boys from more than 20 years ago, and I'm still showing the picture. But we cough to defend the airway, to clear secretions. Cough is an effective mechanism for clearing secretions, but cough is also very good for the microbes. You can see here Dr. Beltadon entertaining strangers by coughing up the cold germs. And in fact, one of the reasons we cough is to spread disease. It's a trigger for both us to get rid of the material, but also for the virus or the bacteria to spread. The cough reflex is very similar to the itch reflex. A good friend of mine is Gil Josipovich, who has written the book on itch, and each time it comes out, I write the chapter on cough and how they're similar. And just like an itch, the more you scratch, the more it itches. Cough is the same. The cough that you continue to cough will lead to irritation, make the cough receptor sensitized, and produce even more cough. And furthermore, some of the medications used to treat itch are now being used to treat cough. So the airway inflammation with chronic cough may be due to the cough itself and is also similar to diseases. Chronic inflammatory cough may respond to anti-inflammatory medications, but that doesn't mean that it's due to asthma. You can have anti-inflammatory medications relieving a cough because of the irritation of the cough. Some medications like gabapentin, which has been used to treat neurogenic chronic itch, is effective for cough, but not recommended in children because of side effects. And now we're seeing newer cough medications, the purinergic P2X agonists, that can block an ineffective cough. In adults and children, and I'm going to say this several times, tobacco smoke is an important modifiable risk factor in causing or worsening chronic cough. And you see here a Shakespearean actor smoking because I guess cough is part of the performance. But cough is worsened with the presence of the irritant in tobacco smoke. And continuing with Shakespeare, should we cough in order to clear secretions, or should we suppress a cough? So a chronic cough in adults is defined as a cough that persists for at least 8 weeks in a patient who doesn't have an underlying reason for cough: non-smoking, immunocompetent, normal chest radiograph. I mentioned that the inflammation associated with coughing is similar to that of cough, which is why we say we wait 8 weeks in adults. And in adults, the 3 most common causes of cough are upper airway cough syndrome, which used to be called postnasal drip, cough-dominant asthma, and gastroesophageal reflux. Upper airway cough syndrome in adults is the most common cause of chronic cough, but there's no real way to diagnose it. There's no specific findings. Although you can see irritation in the back of the throat, that isn't consistent. The diagnosis is really based on giving something to reduce the inflammation, to reduce the postnasal drip, such as an antihistamine. The symptoms are nonspecific, such as dripping sensation, nasal congestion, mucus, cobblestone appearance, but they're not either sensitive or specific. The diagnosis is made by excluding a recent respiratory infection, nasal drugs, exposures, and response to specific therapy. Usually the first-generation antihistamines is what's used. This is important because sinus CT scan is not helpful in making the diagnosis of postnasal drip or sinus disease-causing cough in adults or in children. In this study, they looked at sinus x-rays, and they were found to be abnormal in 82% of asymptomatic children. And in this study, looking at sinus CTs, although 2/3 of these patients had an abnormal CT with chronic cough, also 50% of normal children with a head CT had, and no cough, had an abnormal CT. Now, why would we do a head CT in a normal child? This study was done in an emergency department for children that came in with head trauma. And they took the history of whether they had a chronic cough or sinus disease. And then they went back, and the radiologist independently read these CTs, not for head trauma, but for sinus involvement, and found that half of those children that were completely normal had abnormal sinus. So in adults for rhinitis, environmental tobacco smoke exposure, particularly in children, nasal steroids for allergies, antihistamines, decongestants are not recommended. In non-allergic rhinitis, topical antihistamines may work, and the older antihistamines are used in adults, the one that make you sleepy. Gastroesophageal reflux disease is also common in adults. It probably occurs in more than 40% of adults. We see it associated with obesity. We see it associated with a variety of things. Chronic cough is certainly present in 1/3 of patients with reflux, and 44% of adults evaluated for cough had an abnormal acid reflux. But the question is, does the cough cause reflux, or is the reflux causing cough? Well, this study that was published in adults said 80% of asthmatic adults have a positive pH probe, but neither antacid therapy or any other therapy for reflux improves the asthma symptoms in children with severe asthma, and in fact, it was associated with significant side effects. In adults, the therapeutic response to antacid drugs is the most cost-effective way for diagnosing reflux-associated cough. And finally, the 3rd common cause in adults is cough-dominant asthma. We used to call this cough variant asthma, thinking that cough was the only manifestation. But in fact, most of the patients, if not all, that have cough with asthma have other symptoms of asthma. They have allergy, they have wheezing with virus infections, they have a nocturnal cough. The diagnosis is made by an examination consistent with asthma, exclusion of other illness, and bronchoprovocation testing. And this time we're looking not for bronchospasm, but for cough. Cough-dominant asthma, as I said, almost always has other symptoms. And it probably manifests as something that we call secretory hyperresponsiveness. We know that bronchial hyperresponsiveness, hyperreactive airways, is when the airways constrict when they're exposed to something. And we treat that with bronchodilators like salbutamol. And we know that asthma is also associated with inflammation. And we know that asthma is associated with hypersecretion. And in some patients, that secretory response is what's dominant. And these are patients that we'll often see that have disorders such as cough asthma. And it's more difficult to treat because it responds poorly to bronchodilators because it's not bronchospasm, and it responds poorly to corticosteroids. But it may respond to anticholinergics. Now, children have a different definition. This study by Anne Chang and her group out of Brisbane, and Anne is probably the most famous cough pediatrician. She does wonderful work. Defined it as a cough that lasted for 4 weeks, which makes it a bit difficult to compare with adult cough that lasts 8 weeks. And she said the difference between the adult and pediatric definitions are that children aren't small adults. I was the associate editor of Chest that received this paper, and I said, we have to publish it. It's the largest study on cough. But I said, I have a problem with it because you can't start changing a definition just because children aren't small adults. So the editorial I wrote are that pediatricians aren't small internists. And I argued that although children with cough may have different definitions, they're more likely to present with genetic or congenital disease, such as cystic fibrosis or ciliary dyskinesia, and their cough reflex arc is very similar. So in these patients, she studied 105 patients. They all had immunoglobulin subclasses. 102 had bronchoscopy, and 42 had CT, and 6 of these patients had bronchiectasis. What they didn't do was asthma therapy or spirometry or pH probe or therapy for cough reflux. And what they found was that asthma was only in about 4%, upper airway cough in 3%, and reflux in 2%, 3%. What they found was that most of these patients had something called protracted bacterial bronchitis. Now, waiting 4 weeks and then bringing them back for the studies a couple weeks later, about a fifth of them responded before therapy. But these were the diagnoses: asthma, aspiration, reflux, upper airway cough syndrome, tuberculosis. So what is this protracted bacterial bronchitis? Well, the group from Brisbane said it's the most common cause of chronic cough in children. They have a wet cough, and they have neutrophils in their bronchial lavage fluid. And if you isolate pathogens, you'll see Moraxella or non-typable Haemophilus, things that we don't usually consider to be particularly pathogenic. The airways didn't have purulent secretions. They didn't have immunodeficiency. But the treatment was 2 to up to 8 weeks of oral antibiotics. So is antibiotics really necessary? Well, in this study, they looked at the bronchoscopic findings, and they found that in patients with non-purulent bronchitis, they had fewer positive BALs, but they still had neutrophilia, and no, they did not have eosinophils. Because that viral cough is common, after 3 or 4 weeks, will they need antibiotics? Will antibiotics after 3 weeks hasten the resolution? And if we waited 8 weeks, would they have the same diagnosis? So this same group from Brisbane looked at giving Augmentin, amoxiclav, as they call it in Australia, for 2 weeks. And in those who received placebo, they still had a significant cough score. 2 weeks of the antibiotic decreased the cough in almost all. And so we've come to accept protracted bacterial bronchitis, PBB, as not the most common, but a more common cause of cough in children, particularly young children with a wet cough. So what does cause chronic cough in children? Chronic purulent cough, where you're expectorating purulent secretions, is always pathologic. It suggests bronchiectasis, cystic fibrosis, immunodeficiency. ciliary dyskinesia, and it requires additional study, and it requires very specific therapy. Chronic lung disease, looking at all of those, is often associated with growth failure as well. Now, tracheomalacia can also produce a brassy cough like habit cough, and this is common in babies who have survived the nursery with long-term intubation. You can also see the same brassy cough with TE fistula, vascular ring, or cleft. However, as I mentioned this morning, because the airway malacia is worsened when you remove the muscle that's holding it open, when you reduce the muscle action with a bronchodilator, they actually get worse. Post-infectious cough can also be due to irritation. Pertussis, mycoplasma, adenovirus we're seeing commonly, and cough inflammation can produce cough. And as I've said before, and I'll remind you one last time, tobacco smoke is strongly associated with chronic cough in children. So does upper airway cough syndrome, postnasal drip, cause chronic cough in children? And the answer is probably. This is an older report by Andy Bush, who said it's the most common cause. And it may not be the most common cause, but exposure to those irritants in the home, repeat respiratory infections, and cough itself can all produce these symptoms. And the treatment with antihistamines should respond within 2 weeks. So does reflux cause cough? And the answer is probably not. Although aspiration can cause lung disease and cough, reflux alone doesn't appear to do it. Aspiration is laryngopharyngeal dyskinesia, ineffective swallow. And these patients can develop bronchiectasis and cough. Reflux alone rarely causes cough. And in fact, studies have shown that therapy for reflux doesn't influence the course of cough in children. And does asthma produce cough in children? And I mentioned isolated cough asthma is uncommon. The earlier studies looking at cough variant asthma were really poorly controlled. So as I said before, unlike smooth muscle contraction, which is rapidly reversible, mucus hypersecretion causes airflow irritation that gets better more slowly and depends on clearance of secretions from the airway. The patients that have a greater secretory response are those that have things like cough-dominant asthma. And we've shown that this responsiveness is due to activation of specific signaling pathways, which is steroid insensitive. So again, Ann Chang's group, there is no evidence for the use of inhaled corticosteroids for the treatment of subacute cough in children due to respiratory infection. And there's no value in using salbutamol or inhaled corticosteroids for treating chronic cough either. But there was a small study that suggested the antihistamine cetirizine was more effective in placebo for seasonal allergic cough, and you see the effect very quickly. So what else will cause chronic cough in children? Certainly things like pertussis, mycoplasma, tuberculosis, HIV. Foreign body needs to be considered because there's no salbutamol or steroid that will treat foreign body. That's for the ENT to remove. And you can get cardiac cough, secondary gain, parental overconcern. The term habit cough is now more appropriately used. These are some studies that we've published looking at patients with habit cough. This looked at over 200, but 96% were children and adolescents. Most patients had no cough when awake, only when they were asleep. Cough only when they were awake, no cough at all when they were asleep. It disappeared. The cough was barking, and it was treated with suggestion therapy. There is, if anybody is interested, Mike Weinberger has a YouTube video, where he treats a child from a distance who has a chronic cough, a habit cough, and treats it very effectively, and the father recorded it and posted this. And many patients now from around the world have watched this video and treated their cough. If you are interested, just Google Weinberger habit cough, and you can send your patients to watch it, and it's incredibly effective. This is Ann Chang. She's this tall. She was standing on some steps. This was in Santiago de Chile. You recognize the place, of course. This is her take on my editorial, but I call it cough suppression. So to treat chronic cough in children, identify the cause, of course, and treat specifically, but recognize that placebo effect in cough is very strong. This paper showed that the placebo treatment for cough gives an 85% efficacy. This looked at cough frequency comparing placebo in the open circles and dextromethorphan in the closed circles, and showed that within 2 hours, both similarly reduced cough. There is also a great study in children where the parents brought the child in and the doctor gave them either placebo or a cough medication, which in this case was an antihistamine, or nothing. And they came back 2 weeks later, and the patients that received the antihistamine or the placebo had equal good benefit. Those that received nothing were still said there was a cough. The placebo effect is strong, which makes it difficult to evaluate these studies. So there's no evidence for using typical airway clearance, such as chest physical therapy or vests for treating chronic cough, unless it's purulent cough and you're treating bronchiectasis. And there's no evidence for using over-the-counter medications, such as decongestants, antitussives, expectorants, or mucolytics, or hypertonic saline, which itself induces a cough. These over-the-counter cough medications, decongestants, expectorants, are associated with morbidity and even death in children, and there is a reference. So we did a large study looking at Mucinex, which is a form of long-acting guaifenesin. And we found that it doesn't increase sputum volume, so it's not really an expectorant. And cough with a respiratory infection, there was no difference between Mucinex and placebo. We went on to study this in the research laboratory where patients would inhale a tracer and then take Mucinex. And we found that there was no difference between placebo and Mucinex in either mucociliary clearance or cough clearance. And so if you're going to treat cough and you're thinking it's just for a cold, most of these medications have no benefit, and in children they can be dangerous. And I put this up because the Food and Drug Administration in 2007 sought to ban cough medications for infants. They were initially voluntarily withdrawn, and 5 years later, they recommended they not be used in children at all. They're still sold, they're still given, but not used. And it's interesting to me that when the Food and Drug Administration started 110 years ago, it was to protect our food and to make drugs safer. And one of the most important drugs they were trying to make safer was used to treat chronic cough. And you can treat cough with heroin. And this led, one of the things that led to the beginning of the FDA, although it's completely true that if you do take enough glycoheroin, you will never cough again. So with that, I thank you, and I am so pleased to be here again with friends. Mucho gusto. It's good to see new friends, and gracias, muchas gracias. Preguntas? Are there questions?
Question, preguntas
En español.
en español, en inglés.
Primero, muchas gracias, Bruce. Esta plática es una de las pláticas sagradas para nosotros. Es indudable el mensaje que nos dejas. La pregunta es, what's the next step when you use 4 weeks of antibiotics in protractable chronic bronchitis and you use 2 more weeks or 4 more weeks of antibiotics, amoxicillin, acyclovir in the bigger doses, 90 milligrams per kilo per day, and 3 times a day, because that's what Anchang has been learning to us. And the child still having chronic wet cough. I know part of the answer, and we're making a Wednesday study for that with you, but I want you to tell the audience.
Yes. I take those children and I send them to Brisbane, Australia to see Dr. Chang. That's a very difficult question. Yes, we are going to talk about the role of other anti-inflammatories such as macrolides, anticholinergics such as ipratropium or tiotropium sometimes. But if they still have a cough after 2 rounds of antibiotics, N would say they probably don't have PBB, and you need to look at other things. These are children that you may need to do a CT scan to look for unrecognized interstitial lung disease. As you know, sometimes that won't appear on a chest radiograph. You need to consider habit cough and see very carefully if the cough is at night. All of the things that you're already doing, Edgar.
Una más.
Thank you. I like your talk. During the pandemic, we saw some kids that will have COVID, and the idea was that kids would not have COVID, which you and me know that didn't happen. But some of them had really persistent cough. I know one case that was really sad. 9-year-old, he lost his voice completely. And we didn't know exactly what happened. It seems like something neurologically with the vocal cord, but he couldn't talk for months, 6 or more. It required intensive rehabilitation, and finally he started talking again. But it was a sad case, and I know that it's not the only one because I have seen reports in adults. So I think that was under-recognized with COVID. Anything that we missed, like pediatricians in that time, that we didn't do right, that maybe had been facilitated if we do more education or know exactly what to do with those cases.
Thank you. Thank you. I've not seen children who've lost their voice, but I have seen children with COVID, even mild COVID, who went on to cough and to cough and to cough. And I wonder if the presence of the virus triggers an inflammation that continues and continues. But they didn't respond to steroids, and they didn't respond to all the usual things in our bag. And often these children would get better initially from their COVID, and then would become tired and cough. It often goes along with fatigue, and I have no idea what's happening. It would be interesting to pull all of the information from many places, but thank you, I thought I was one of the only ones seeing this, and I don't know how to treat that cough.
Una más.
Congrats for an excellent conference. I want the questions. Are you going to use suppressant cough in pertussis?
I am not going to talk today about cough and pertussis. However, these new medications, these P2X agonists that are being used in adults with very chronic dry cough that we'll see with cancer or things that are incredibly effective. The company that made it, Afferent, was bought by Merck, and they're just starting to look at studies in children. They don't see that children have such long-term chronic dry cough. And several of us are saying it must be pertussis. That has to be where you start, because there's nothing that we can do for it, but it fits that exact category of a chronic dry cough with this aberrant cough reflux. So right now there is nothing that I know that helps pertussis cough other than time, but I'm cautiously optimistic that some of these new medications that have seen benefit in adults may also help our children.
Okay, thank you very much.